see. Okay, do you want to try now?
Same deal.
Okay. Let's see. Katie, are you having the same problem? Is it still saying that you can't turn on your video as well?
Yeah, mine says the same thing.
Okay, let's see. Katie, I'm gonna pull together these slides real quick. Do you mind if I make you the host just for a second to see if you can see what I'm seeing on my end for the video?
Sure.
Thank you.
And Katie, my name's misspelled. It's Heidi. It's H-E-I, not H-I-E.
Perfect. I can change that.
Thank you. Thank you.
No problem.
Heidi, did I misspell your name?
I don't know.
Was that on the presentation or is that somewhere else?
I think it's on the presentation. I'm looking. No, you got me.
Okay. Phew. Kayla, do you want me to drive and share my screen or do you do that?
I was going to go ahead and share my screen with the presentation, and then if you would just like to indicate when you'd like to switch slides, I'd be happy to do that for you.
Sure. I'm going to really kind of glaze over a few. Will participants get copies of the slides afterwards?
If you're okay with it, then yes.
Yeah, I am. If you could just make it a PDF file, because some of my formatting is pretty wonky. But yeah, if you make it a PDF, I'm happy. Yeah, and that'll be good. So I can definitely glaze over some of the more wordier slides and just assure them that they'll get access to it.
Perfect. Thank you. I will do that.
Thanks.
Yeah, and sorry, I'm not seeing a way to make the panelists able to go on video. I don't know what the issue is there with that. So I'll keep looking and see what I can find there.
I think Stephanie and Emily might still be attendees and they don't have access to unmute right now. And I think Stephanie said something about it in the chat box.
Okay, I will promote them.
Yeah, I think I got signed on as an attendee through a registration link. I don't know if there's a separate one.
Oh, Kayla, I think it might be, remember when you set up the Zoom webinar, there was that checkbox for the panelist video? I think that might be the issue.
Okay, let me go back in and click
that. I'm here, but I don't have it's not letting the video show. Looks like Emily might be having the same issue.
Yeah, we're working on the video right now, Steph, but we can hear you.
No problem. Hi, Tavio and Heidi and Susan.
Hi, Stephanie.
We have, I think we have over 200 people registered for this event, so we're super excited.
We're excited too, and I have another question. Gotta love these last minute things, but we still have 9 minutes, which is a light years.
Yes.
We had originally talked about how Susan and I were going to go first because I have to be off by 11:30.
Yes, that is the, let's see. Okay, I just turned sorry, I was just changing that note. The webinar right now. Yes, Susan and Heidi are presenting first.
But it says we don't start until 11:30.
In your email.
Yes, we were going to go over some back to the Immunize Colorado updates. But if you need to present first right off the bat, then if you'd like to go first right at 11, we can save our Immunize Colorado updates until the end.
I'm so sorry. I thought April had let you guys know. I have a hard stop at 11:30. So that was why we were asking to go first, was to do that. So I appreciate your flexibility. I'm sorry to ask for that.
No. I'm so sorry. That must have just been a little bit of an oversight on our part, but that's absolutely fine. I just sent the slides over now, so the slides might not reflect that, but I'll scroll down to your slides to present that at first.
Thanks, Kayla.
Katie, I changed that function on the Zoom webinar. Can you see a difference now?
I'm not seeing a difference. Any of the panelists, are you able to turn your video on yet?
No, but I got another email saying that I'm a panelist. So should I get off Zoom and get back on with this other link? Okay.
I think that's what we'll have to do for the video.
I'll try that right now.
So we should all do that?
I think so. Yeah, I think it will need to reset the settings.
Sorry about this, Katie. It's a little hectic.
Oh, no worries. If you need me to do anything else, Kayla, I know it's a lot to manage, so just let me know.
No, that's okay. I just sent the slides over.
Perfect.
So I'll pull them up on my screen.
So I just logged back in with the other link and it's still not letting me share video. Let me see.
Would it be easiest to make all the panelists also co-hosts? I don't know if that's possible or if you can have just a limited number, but it seems like Katie can also share her screen or like share her video as a host.
That's a good idea.
Yeah, let's try it with you, Ellie. I'll make you host.
I didn't get an updated link.
Ellie, are you able to turn your video on now?
Yes, I can.
Okay.
So can you still see me?
Yes.
So do you think that maybe we should just pass around the host function so that everyone can turn on their camera? Or what do you think the best solution would be?
Yeah, I think we'll just have to pass around the host. So Ellie, if you want to make Heidi the host, and then Heidi, I think you can turn your video on. And then if you want to make Susan the host, she should be able to turn her video on.
Okay. Ellie, you tell me when to try.
I think you can try to turn your video on now.
Hey. Okay. Now I have to share host status.
Correct.
Or I'm going to ask the dumb question. Where do I do that? Under participants?
So you will
If you hover, yeah, over the box in the right corner, there's the 3 dots. I think it should be there.
Okay, perfect. Susan, try it.
Hey. Hi.
There. And then Tavio, I'm not sure if you want to be on video, up to you, but Susan can make you the host so you can turn your video on.
Yeah, that's totally fine.
How do I do that? So I click on the 3 dots in my video box?
Hover over
On Tavio's video box.
Oh, over Tavio. Okay. Gotcha. All right, done.
Just when I thought I was a Zoom expert, turns out more to learn.
There's always something, yeah.
Tavio, are you there?
Yeah, what's up?
So we ended up making you the host so that you're able to turn on your video. So if you wouldn't mind just turning on your video and then passing it back, or making the host Stephanie Wasserman, who just logged on.
Sure thing.
Thank you.
I'm still having that issue with no video. It says the host has stopped my video.
Once I transfer it over to you, Stephanie, I think we'd be good then.
Okay, thank you.
No worries. I made you the host now. Try to flop it on.
Oh. Got it. Thank
Here we
you.
go.
And then Stephanie, one more round robin. Would you mind clicking and making Emily the host?
So how do I do that?
There's 3 little dots in the top corner of Emily's box. And if you just click that, you can make her the host.
Oh, in Emily's box? I see. Make host. Got it. You want to change?
Okay.
Okay.
And then Emily, one more time, would you mind making me the host? Sorry about this, guys. Okay, perfect. Well, we've got about 30 more seconds until 11, so I'm just going to wait and just make sure that we have everyone logged on for the webinar. Thank you. Okay, so I'm going to go ahead and get started. I just want to first of all welcome everyone who's logged on to the webinar for today's session. Today we'll be going over back to school immunizations during the COVID-19 and strategies for keeping kids vaccinated and protected in schools this fall. Today we've got Heidi Baskfield, Susan Goldenstein, and Tavio, or I'm so sorry, Tavio, Porcini.
You can just call me Tavio. It's fine.
Okay, sounds good. And we've got Tavio. We're going to start off a little bit, we're going to start off with today with housekeeping. Right now, all attendees will be muted for the presentation. If you have any technical difficulties, please use the chat box and the staff member will assist you. We'll be conducting all Q&A at the end of the presentation, so please add your questions to the chat box throughout the presentation and we'll be asking them at the end. Please take the time after the presentation to fill out our post-evaluation survey. And in this meeting will be recorded and on our website and available next week. And on that note too, if you'd like any of the slides from our presenters today, please reach out to us and we'd be happy to share those resources as well. We are first going to start off with Heidi and Susan's presentation. And they are just giving you all a brief overview of our presenters today. We've got Heidi Baskfield. She is the Vice President of Population Health and Advocacy at Children's Hospital Colorado. Heidi has joined the team in Children's Colorado in 2009. Her current responsibilities are focusing on leading strategic population health, advocacy, and legislative efforts to influence child health. In addition to that, she manages and oversees the hospital's global health programs. Heidi believes in community connectedness and serves on the board of such of the University of Colorado Campus Community Partners, Coloradans Protecting the Patient Access, and the Denver Chamber of Healthcare and Coalition, and the Colorado Education Leadership Council and Family Community Partnership Subcommittee. She's earned her law degree from California Western School of Law and received her bachelor's degree in political science from Fort Lewis College in Durango, Colorado. So welcome, Heidi. And then next, I'm going to introduce Susan Goldenstein. She is the School Health Prevention, Education, and Outreach Manager at Children's Hospital Colorado. Susan is a school health manager at Children's Hospital Colorado, where she manages primary prevention and clinical care programs in school settings. She also leads the Colorado Alliance for School Health, which is a collaboration of 13 education and healthcare organizations that work together to transform how healthcare and education partners create substantial systems and health equity in Colorado schools. Since the onset of COVID-19, she has been involved in a variety of school reopening plans and at the state and local levels. So welcome, Susan. Next, we've got Tavio. Tavio is a data analyst with CDPHE, a part of the Colorado Immunization Branch since 2016. In his role, he facilitates the school and childcare immunization data reporting project, creates data visualizations, and works with the Vaccines for Children program to improve data quality and efficiency. Prior to joining CDPHE, he's worked with the Department of Labor and Employment and Apple, providing customer service on a broad range of topics. Tavio has a bachelor's degree in arts from the University of Alabama in quantitative economics and mathematical statistics. Additionally, he holds a master's in arts from Colorado State in economics. Most recently, he's been heavily involved in the state's COVID-19 response, designing and launching the new statewide COVID dashboard that it has been in a dual spanning immunization and COVID data. In his spare time, he continues to play on the ice, plays ice hockey, and enjoys Colorado with his dog. So welcome, Tavio. So with that, we will go over Immunize Colorado updates at the end of the after both presenters have presented. So Heidi and Susan, please just let me know when you'd like to switch slides.
Great, thank you so much. Oh, that sounds bad. I'm going to go ahead and get started. So we created this summer a variety of school reopening guidance documents in the form of like white papers that we wanted to help schools work on reopening. So the presentation we're going to share today is some of that thought process, of which vaccinations is key to schools reopening. Go ahead and switch. So the three things Heidi and I are going to go over. First, we're going to present to you our risk assessment tool in a broad sense. At this point, plans are in place and it's happening, so we're not going to get too detailed on that, but in a broad sense, introduce that to you. Then we're going to get gritty with how to apply these concepts into the school setting and how to manage COVID outbreaks or positive tests in school settings. And then all along the way, we're going to share some resources with you. Go ahead. So we all know that with the closing of school, it's been a mixed bag of results. So we know that we flattened the curve successfully, which was the key goal. But it also came with some negative implications. And we know that our North Star is keeping schools opened. And so how do we manage both of these? How do we keep the curve flat and also preserve in-person learning and the rich benefits of that? Next. So again, just acknowledging that having open schools open for in-person learning is our key goal, both of the hospital and of educators, but we need to do it in a way that protects everyone involved, which is new and different than what we've done in the past. Next. So a couple of things before we get started is to kind of acknowledge some unsubstantiated practices. And these are questions we get frequently from a variety of education organizations. So first of all, there is no, no blessed teacher to student ratio. How many kids can actually be in a classroom per teacher? There's nothing in the evidence that really gives us that information. So that's not something that we're going to talk about. Testing, there's lots of ideas about testing. Do we need to test all kids before they start school? Do we test all teachers? At what frequency do we test? And the answer is really none of those. None of those are really good predictors of active COVID unless you are having symptoms and having, other signs that you may have an infection. So any kind of broad testing is not something that we're going to recommend at this time. Ultraviolet light, that's another one we get a lot, I can't even count how many times I've been asked this summer, but, is there a period of time that we can quarantine like books or toys out in the sun or on a shelf, without having to actually disinfect them before kids can use them again? And the answer is we just don't know. COVID, as everyone knows, is a fairly new virus, and we don't have the level of research that we need to substantiate that type of practice. And then the last thing we want to talk about is PPE. And there's been lots of ideas and suggestions about a variety of PPE that people might want to introduce into an educational setting. And the bottom line is we really don't need to. Besides face coverings and masks and some additional PPE for health room aides, we don't need mass PPE practices amongst teachers and students outside of symptoms. So I wanted to just acknowledge those. There's going to be some slides that are really wordy like this. I'm not going to go over that, but we will provide this to you afterwards, and you can go back and read up on those. Next. So our model is 3 phases, 3 tiers. And so the first tier is kind of your basic, standard core principles, the most effective, the things that everyone needs to be doing this whole time. And then the second tier are things that you can add on to tier 1 to improve the safety and reduce the risk. And then the third likewise are concepts you would add on to 1 and 2 that you're already doing to further reduce the risk of having in-person instruction. Go ahead to the next one. So with tier 1 practices, the core basic functions is hand hygiene, right? So we need to make sure we're teaching students and teachers about when they need to wash their hands, using sanitizer. It's not just after you go to the bathroom, but after you touch a common surface, using doors, things like that. So really upping the game on hand hygiene makes a big difference. Distancing also makes a big difference. I want to acknowledge that 6 feet is not a magical number. It's just the greater distance you can bring between yourself and another person, the lower the risk of transmission. And of course, wearing face coverings is important in that formula. And then vaccinations. So we have been very clear that we want kiddos to be up to date on their well child checks and their vaccination schedules ahead of going to school. That's a practice we promote prior to any school year, but even more so these days. The last thing we would want is an outbreak within an outbreak. So vaccinations obviously are key, and I know we'll have other speakers today sharing more information about that. Next screen. So face covering, some other common questions that we've been getting from partners around the state. First of all, we need to comply with the mask order, which dictates that anyone over the age of 10 must wear a mask or face covering outside of the home when they're not able to keep that 6-foot distance. For school children, we do want to recommend that kids under 10 do wear masks. They can, most of them can, but also acknowledge that schools and districts could have some variances there. So we want to abide by whatever policy is put in place, but we do encourage children under the age of 10 wearing masks over the age of 2. So who should not wear masks is children under the age of 2. We don't recommend wearing masks. Children who are having trouble breathing, so in the midst of an asthma attack or flare, they should not wear masks. But outside of the asthma attack or flare, children with asthma and other chronic lung diseases should wear masks. And that's highly recommended. And a lot of times those kiddos will wear masks during normal respiratory seasons, even when the date's not 2020. And then the other consideration we want to give is to students and children who have a history of trauma that would be triggered by wearing a mask. So if they've experienced some sort of trauma in their life that had to do with, restricting breathing or covering their mouth, things like that, that might be a trigger, we want to honor that and really make whatever accommodation is appropriate. For children who suffer with anxiety and autism spectrum disorder, we know that working with an OT to build up mask wearing tolerance is effective over time. And, they're not going to be able to wear it for 8 hours on the first day. I think that would be a struggle. Some kids might not be. That is something they can work up towards, and trying a variety of different types of masks could also help with that. Next. So tier 2 is when we start screening. So hopefully most schools have put into place screening protocols to where kids are screened at home, which is really important. We don't want kids with any symptom on a bus or at school, because those are two places where they're going to be exposed to other people, and that's exactly what we're trying to prevent. So we really need at-home screening, and screening of the common symptoms, which we'll go over. Any of those, the child needs to be excluded from school, kept home, and then inform the school and or primary care provider for next steps on those symptoms. Next slide. So screening tools, districts have adopted different versions of this. A lot of them have gone web-based or app-based, where the parent can log their symptoms on a daily basis, and that's basically their ticket to school. We do need to have considerations over, our student population and where there may not be access to smartphones or broadband or data plans, things like that. We need to have a pen and paper option for those parents, and then lots of reminders and enforcement. So we really need to make sure parents are complying with whatever policy your district has put into place. Next screen. And so on that note, to kind of help fill that gap for families who may not have access to a web-based or app-based screening program, we have created these symptom checker pads. These are little, like a prescription pad, a pad of paper. There's about 100 on a pad. And the parent can do this at-home screening with their child. And if they don't mark yes on any of those symptoms, then they can give that paper to the child and they can take it to school, and that's their record of having a symptom check that day. And so we have these in English and Spanish, and we actually have these in Mass at the moment. So if you have a school or community who needs these, please reach out to me. My email is there, and we'll provide it again in the chat box when I'm done. Please reach out to me and I'll be glad to send you how many symptom pads you need. They come in boxes of 80, and we're thinking, since there's 100 sheets per pad, that it would get a student or a family through at least the first couple months of symptom screening, and then we'll kind of see where we're at. But if your community is in need of this resource, please reach out to me. I'll be glad to send those to you. Next slide. So symptom screening, you need to exclude the child from school, keep them home, and then call the school and or your doctor for these symptoms. And we've categorized the symptoms into two pieces, so either high risk or low risk. And this was done in conjunction with our infectious disease team at Children's, who have worked with us all summer on these recommendations. And then also it's fully in line with CDPHE. So your high-risk symptoms are your fever, chills, cough, shortness of breath, difficulty breathing, and then loss of taste or smell. Low risk is more your sore throat, runny nose, achiness, headache, fatigue, and vomiting or diarrhea. So kind of using those two categories is when we can kind of start to self-assess about when we need to engage with further care. And so there's kind of two categories under that. We have sustained community transmission or low community transmission. Sustained community transmission is your safer at home and your stay at home orders that we have with the state right now. And then your county could potentially apply for a variance that might put you into that protect your neighbors category. And I tried to look to see if we have any counties under that right now, and I couldn't find any information on that on the CDPHE website. So as far as I'm aware, we're in the safer at home or stay at home order broadly across the state. And so with those, if you have high or low risk symptoms while you're in those two orders, meaning that you have sustained community transmission, then you need to engage with your doctor to help evaluate your symptoms. If you're in a community of low transmission, then you really just want to focus on those high-risk symptoms, because the chances of you having COVID-19 are much less than they would be if you have sustained transmission. And then, of course, everyone needs to stay home for 14 days if they have had contact with someone who has been confirmed to have COVID-19. Next slide. So tier 2, the next layer of practices you would want to build to reduce the risk of transmission in your school is to exclude. So kind of what we just talked about, identifying criteria for when kids should not be in the building. If they show up with symptoms, they need to be isolated right away. And there's clear guidance on how to do that in schools from CDE and CDPHE. Pod style learning, the cohorting practices that a lot of in-person districts have implemented, really help to keep groups together, so that when it comes time to contact tracing, you have clear-cut boundaries already set on who would have been exposed. And then touch-free surfaces. So we want to reduce the frequency of touching shared surfaces. And an example of that is like the door. So when it's possible to leave a door open so that there's not everyone opening the door, that would be really helpful. And we know that opening doors to the outside is not endorsed in schools because for safety reasons, but interior doors, if there's any way to have those open, ideas like that is what we mean by touch-free surfaces. Next slide. So your tier 3, again, the next layer to really kind of button it up and have a low-risk environment for in-person schooling is to enhance your cleaning. So more frequent cleaning during different parts of the day in high traffic areas. You have to enact contact tracing again. And the key thing with contact tracing is really working with your local public health agency. That is their role, but schools will assist with that. Increasing your airflow and ventilation, and then communication. Lots of communication with parents and staff. Next slide. We created 2 white papers, and I have links here. I'll put the links in the comments in just a second. But one white paper that's specifically on this framework, and then the next white paper is on managing the symptoms in schools. And that is what Heidi's going to go over in just a second. So links to those papers are in this presentation, and we'll get those shared also. Next slide. All right, I'm going to turn it over to Heidi.
All right, friends. Susan, thank you so much. One of the other things that we definitely want to call attention to is that all of our content has been developed in tight partnership with our infectious disease team, some of whom may be participating on this call and webinar today. And so we just want to give a huge shout out and thank you to those team members that continue to be a critical resource to our community and engage in regular partnership with our partners at CDPHE as well. And I'm sure, Tavio, you were going to say the same exact thing, so I'm just doing that as well. But we sure appreciate all that CDPHE is doing with us to try to help support our schools open and operate safely. Let's go ahead and move into the next slide. I'm going to move through these pretty quickly. Want to talk about some specific scenarios. What we tried to do was create as many scenarios that we thought parents, staff, schools were going to have to navigate and provide guidance to those. What we have already found is that for as much thought as we have given to this, there are any number of variations to these circumstances that warrant ongoing conversations. So please consider us a consistent resource to any of you who may need additional information beyond what we can provide today. So what we're trying to do here, again, is just ensure for the safe and thoughtful return to in-person learning based on what's happening in the community, of course, as our major informant on what we can do and when. Next slide. So let's talk quickly about exposure and how do we define exposure. And that's really someone who's been in close contact with someone who's got a confirmed positive COVID test or is suspected of having COVID. So in close contact is really defined as being within 6 feet of that person for 15 minutes or longer. So with respect to school situations, what you can tend to assume is that all household contacts are considered close contacts. So when we start thinking about siblings, if we've got one sibling who has been exposed and or tested positive, then that whole house is considered exposed. And similarly with learning pods or classrooms. Next slide, please. Again, going over the high risk and low risk symptoms. We'll spend a little more time on this in each of the scenarios, just saying that you might have some more flexibility in making some determinations with low risk symptoms. And I'll get into what that flexibility looks like in just a minute. Go ahead and go to the next slide, please. Thanks. So this slide was actually done for my benefit because I kept confusing isolation and quarantine. And because I work at a children's hospital, we used a kid-friendly approach to distinguishing the two, and it's helped me a lot. Hopefully it's helping some others. So isolation is really for those who have been confirmed sick, hence the highlighting on the S. So you isolate for no less than 10 days if you are sick with COVID, and you really can't return until you've been symptom-free of high-risk symptoms for 24 hours, and that's without medication. And if you have sort of those central tenets of the cough and runny nose, as long as those symptoms, you've hit your 10-day mark and those symptoms continue to improve, it is safe to return to school. Quarantine really is about questioning. So if you've been exposed to someone with COVID, quarantine is really a spread management technique, which we are all familiar with, that we are then in lockdown for 14 fun days. Next slide, please. All right, so let's get into these scenarios really quickly. So what's going to happen when a student or staff person screens positive? So here are some quick and simple pointers. If someone screens positive, they need to stay at home and contact the school. And we need to begin to understand whether or not there have been other members in the household who have been exposed, and whether or not the timing of when a person was positive may impact school operations. So if a child was in school on Wednesday, they tested positive on Thursday or Friday, when that person contacts the school is actively going to engage in a process where they contact local public health, and that classroom will immediately be placed into quarantine, and a broader contact tracing effort will commence thereafter. So for people who are positive, you're going to be on 10 days, again, until you can be symptom-free for 24 hours at least following that 10 days. And those who have been exposed to the person with a positive test are going to be on quarantine for 14 days. And it doesn't matter if they never develop symptoms. So if my kiddo's in a class with another child who has a positive test, we're on quarantine for 14 days, even if my kid never develops symptoms. Next slide, please. So what happens when someone doesn't experience symptoms until they're at school? So I know we're all doing the best we can with implementing safe practices for screening, and it's never our intention for staff to show up sick or students, and sometimes it's just going to happen. So when that does happen, what needs to be in place is a very clear process on how to engage in immediate isolation, either of that staff person or that student. So if we're talking about a student, we need to have a clear process by which symptoms are identified, that student is removed from that environment and placed into an isolation place, and a parent caregiver needs to be contacted to come take that child home. The child needs to stay in that isolated space, clearly supervised, until the parent caregiver can arrive to take the child home. If we're talking about a staff person, they also need to be sent home immediately. When we're talking about what does the staff person need to have who's escorting a student to the isolation room by way of PPE, as long as we're practicing our social distancing, hand washing, and face covering, you don't need anything more specialized than that in an effort to be taking kids safely from the classroom to an isolation space. The school is going to need to contact the local public health agency if that child comes back positive. So if a child is just experiencing symptoms at school, that in and of itself doesn't trigger the need to contact local public health. The school only needs to do that if and when they're contacted and informed that a staff person or a student is positive with COVID. Now, some kids are going to have all kinds of things that aren't COVID. They're going to throw up in their classroom. They're going to develop upset tummies and things of that nature that fall within the low risk bucket. When they're in that low risk bucket, and if they're symptom free for 24 hours, the general guidance is that they can return to school. What's going to be tricky is on that fever front. In our society, we're pretty quick to administer medication once we start seeing our kids get uncomfortable with fevers. Kids have to be fever free for 24 hours without medication. And so that's going to be a critical component to informing when a kid needs to see their doctor, when they need to get a test, and when it's safe for them to return to school. Next slide, please. So what happens when a person who was symptomatic wants to return to school? When is it safe? What kind of permission do they need to receive? Thinking of those kinds of things. So schools need to have a health liaison who's going to be the point of contact for both reporting symptoms, reporting positive tests, and seeking instructions and clearance. Again, just to reiterate, if you have a positive test, you have to isolate for 10 days. And you should be getting a PCP assessment during that time. A PCP can always help provide additional information on how to manage those symptoms in whatever way they might be appearing. If you have a test and it's negative, in order to return to school safely, you got to be symptom-free of those high-risk symptoms for 24 hours. And this is, again, where that fever piece comes in. You have to be 24 hours free of a fever without medication managing that fever. And then there are a lot of families who, for any number of reasons, are not going to have access to tests, or they're not going to have access to timely results from a test. So what does that mean? It means if you've got high-risk symptoms, plan on being home for 10 days, unless you have access to a PCP who can give you an actual alternative diagnosis for those symptoms. Both the state and Children's Hospital have said when we're in a situation in our community like we currently are, absent an alternative diagnosis like strep throat, for example, when there are high-risk symptoms present, it's just not safe to return to school until you've either had a test or those symptoms are free for 24 hours and you've been out for 10 days. Next slide. I'm not going to go through this in great detail because the scenarios essentially are mapping this out, but this is a visual way that helps you sort of map the process flow of what to do when someone has symptoms and how you distinguish the process for high risk and low risk symptoms. Again, the low risk symptoms piece is really meant to acknowledge that kids are going to have certain health conditions that should allow for their safe return to school. Not everything is going to be COVID, and we always encourage that families who aren't sure, stay home, call your doc, and get that engagement as quickly as possible. Next slide. This gets into whose responsibility is what in this process flow. So what are students or staff and parents responsible for versus what is the school's responsibility? And Joni, we are absolutely going to send around the slides containing that chart. So don't worry about that. We'll make sure everybody gets that. So if there are symptoms, if you're staying home sick, if you know you've got a COVID test, if you know you've got, even if it's negative, staff, parent caregivers need to contact the school and keep the school in the loop as to what's going on with your children and even yourself. If you're a parent caregiver and you've had a test and you have tested positive, it is similarly up to you to call the school and let them know that you are positive, because it has ramifications on your children and whether or not they have been exposed and exposed others in the school setting. So it's not just if the student has tested positive, it's also parents or other members of the household who may not be in the school that people need to report. Obviously, it is families' responsibility to manage isolation and quarantine safely, and to the extent appropriate, to allow students who are on isolation or quarantine to engage in virtual learning where that's an option. Schools are responsible for contacting local public health when they are made aware of a positive COVID test. So when someone calls the school, they need to call local public health. Local public health is then responsible for contacting individuals and engaging in contact tracing. Schools are going to be expected to provide information to local public health about what has happened in the environment to further assist with contact tracing, and to the extent that schools can, to make virtual learning available for those who are either isolated or on quarantine. Next slide. All right, what happens when a student or staff is exposed to someone who's tested positive? So again, this goes back into, even if you don't have symptoms, you're on quarantine. If you've been exposed, consider yourself on quarantine for 14 days. And if you want a test, you wait 7 days before you go get that test to understand if you are similarly now impacted and testing positive for COVID. What that means is if you start to develop symptoms while you're on quarantine, your isolation day count starts from the time not that you've gone on quarantine, but that you develop symptoms. So what's super fun about all this is that your potential leave out of the school environment could be for a pretty extended period of time. So that's also what's important to know. Next slide, please. So what happens when a student or staff member is exposed to someone who has symptoms but hasn't tested positive? So that means business as usual, and this is why that daily screening exercise is so important. So if you've been around someone who had a fever but came back negative with their COVID test, and you're not experiencing symptoms, you engage in all your daily safe practices, washing hands, wearing a mask, doing your daily screening to continue to monitor for any changes. Next slide. And just to be super thorough, what happens if someone's exposed to someone who is exposed to someone? You know, we like to be thorough. That's also business as usual. So the onion effect, when you start peeling away the layers, the further out you get from the exposure, the less likely it is that you yourself will develop COVID, and you can just engage in the normal safety protocols that you already would. Next slide. And these are the quick buckets, again, reiterating at what point you need to get a test. So anyone with high-risk symptoms consistent with the COVID infection is encouraged to both contact their PCP and access a test. Anyone with symptoms who's been exposed to someone that they know is COVID positive, when you start stacking up those minor symptoms, right, that usually means you're going to have to go get a test. In general, though, asymptomatic kids and staff don't need to get tested unless they know for a fact they have been exposed to someone who is COVID positive, and even then you're waiting 7 days before you seek out a test. Nelda, I'm going to try to address your question here. If a student is taken to the health office with concerning symptoms and requires isolation, does that classroom need to be evacuated and disinfected, or do the students need to stay in the class and not leave the area? It's a great question. And you don't have to do mandatory evacuation of the room where you've had a kiddo who's had symptoms be escorted out. You absolutely should engage in some fun deep cleaning. And you wouldn't need to send those kids home or engage in isolation or quarantine of those kids unless you are then contacted that that child is tested positive for COVID, and then you would go down that track. But in the moment, one sick kid sent to isolation does not mean that the whole class has to go. But it is recommended, obviously, that you start getting out the sprays or the wipes and wiping some surfaces down. If someone's been working alone in their room with a mask off, what is the chance of aerosols in the air when someone else walks in? So generally, if you've been in the room by yourself with your mask off, you're going to be fine. Once someone else comes in, obviously you both want to be wearing masks to the extent that you can't social distance. And I think we'd encourage you to just have on masks when you're co-locating in spaces together. I hope I'm answering your question, Nelda. Feel free to put anything else in there that I didn't cover. Okay, perfect. We so appreciate the opportunity to be here with all of you today. Again, this continues to be an evolving body of work. And I want to say in closing, one of the other pieces that we have been strongly recommending for all of our school partners is that please message how important it is for all your parent families to go get their flu vaccines, and even consider a flu vaccine mandate for staff. This might be the one year where it is more important than ever to wade in on those specific topics with your own staff. So thanks very much. I appreciate being able to be here today.
Thanks, Heidi. Now I'm going to move into Tavio's presentation. So again, Tavio, just let me know when you'd like to switch the slides.
All right, cool. Well, good afternoon, everybody. So I'm Tavio. It's great to meet all of you guys. I wish we were in person. I feel like this is much better in person, but thank you guys all for joining us today. So I'm going to talk about the school and child care immunization data, kind of what we did for last school year. So all the data we're talking about is going to be school year 2019 to 2020. And then in the end, we'll kind of look a little bit into the future as to what our goals are going to be for 2020 and 2021 with all the COVID stuff. But yeah, if you guys want to go ahead, move forward, thank you. So real quick though, because I know there's stands right now at 193 of you who are on this call. That's a lot. But I'm going to kind of go over just real quick the background, what this project is, what we've been doing. I've really condensed the background part of this since this project's been going on since the 16-17 school year. And I just feel like that at this point, everyone knows that we at least collect this information. So here's what we collect and from whom, of course. So it's all K-12 schools and any licensed childcare preschool that's licensed for 10 or more children. This includes private schools, public schools, religious schools, anything of that nature. The vaccines that we collect, all of those are the required school vaccines and when they become required. So DTaP, Hep B, polio, MMR, and varicella are collected for any age group since they're always required in some dosing fashion. Tdap we only collect for 6th grade and up students. And then Hib and our pneumococcal PCV are only collected for child cares and preschools, since after that the students will age out of it. As far as what information we collect, kind of group it up into 3 groups, and that's how our visualization is designed as well. So we have our fully immunized and our in-process section. Fully immunized, I think, is pretty self-explanatory. In-process trips people up at times. So what that is, though, is that's when a parent has indicated to a school or child care that their student or their child is in the process of catching up on the vaccinations. Possible reasons could be we have a doctor's appointment scheduled for a few weeks. That was the earliest appointment. Or we're waiting for minimum intervals to pass to get the next dose of the vaccine. Any of that all is going to fall within the in-process section. So for exemptions, we have our medical, religious, and personal exemptions. And with some recent passes of legislature, I do expect some of those categories to maybe get rolled into just non-medical and medical exemptions at some point. And then our non-compliant section, no record and incomplete record. I think no record is pretty self-explanatory. Incomplete record kind of becomes our grab bag for what could commonly be referred to as not up to date. But that's just incomplete record is an all-encompassing idea for what somebody who's not up to date could be. And then how, of course, we collect this information. We do have 2 methods now, one of which is gaining more traction. That's the second one on there, and I'll talk about that in a minute. But facilities manually do enter their aggregated data into our web application. And then we did, this year we had 12 districts who submitted electronic data to us. It's all de-identified student level vaccination data. We've kind of come up with a FERB compliant method. That's what I'm going to talk about next here. So we want to go ahead and go to the next slide for me. Thank you. Electronic student level data reporting. So this is kind of our, I guess, new and fancy way of collecting reports. I think it's much easier for school districts. Unfortunately, for anybody who's on here for child care or private preschool, not something that's available yet for you all. But anybody who's here from a district or school district, works for a school district, is a nurse for a school district, anything along those lines, this is much easier since it saves you guys a ton of time. Does involve the use of district IT, though, since they're the ones that ultimately will create this file and send it to us. But it's a pretty novel method, though. So FERPA actually is going to protect the date of birth and date of vaccination, both, for any of the students. So that makes it pretty hard to receive any kind of student-level data and still abide by FERPA. What we've come up with, though, is that the days after birth of shot is not a piece of protected information. It's just an arbitrary number in their mind. And so we have created essentially a custom validation tool that interprets vaccine data as days after birth of shot. And after writing that validation tool, that is about the only way that now I see vaccines. So every time people talk about dates, I'm lost. I always have to look at it as days after birth of shot. So again, it's a pretty novel method. We're very happy with it. And I know the 12 districts that participated last year, and then for a few of you, though, this has been the third year you've participated in this fashion. I think at least what I've heard from everybody, it's been a resounding how much easier this has been for all the school nurses and pretty much everybody involved. I think it puts everybody in the right position to effectively do their job. School nurses focus on getting students up to date, focus on getting their vaccine information put into their student information software, like Infinite Campus. District IT works on actually pulling out information from their student information software, and then we at State Health Department do vaccine validation. So it really puts everybody, I think, in the appropriate shoes, and doesn't really have people stepping outside of maybe what they are, naturally doing day to day anyway. Really great method, I think. And this year we got about 50% of our K-12 students who came in this way. I say 12 districts, then 50% of the students. We have a lot of the large districts participating this way, but we're open to any district who has the capabilities IT-wise to create a file like this to participate, and we're happy to lend as much help as we can for it. So I'm going to go ahead and go to the next slide here. We'll actually start getting into some of the data that we got reported from last year. I'll pause for a minute here with this up here. I'm extremely proud of everybody who worked on this year. All of our school nurses, all of our local public health agencies, our primary care docs, anybody who essentially, I did mention there, who had involvement with students. I'm very proud of it, but especially though, I got to hand it to the school nurses though, who did this reporting this year. All of our reporting numbers are up in masses, and I really couldn't be happier with the attention and the effort people put into this. So for our K-12 schools, we do see a small fully immunized uptick and a small decrease in non-compliance as well. Exemptions pretty much stayed the same, all hovering about 3% per vaccine. At the end of this presentation, there's a link for our new redesigned data page, and if we've got a second, I'm more than happy to share the screen and kind of show that off as well. But you guys can kind of see a lot of the data that I'm talking around. I'm just going to highlight a couple of the things in the slides, though. Primarily, again, it's the reporting aspect, though, where we do see, at least for K-12 schools here, significant jump in number of schools and the percent reporting, and again, almost 55,000 more kids that we know about. I do think, though, there's two things to note here, although we do see a great rise in the reporting aspect. Fully immunized, non-compliance, small upticks, but relatively constant. So even though reporting does fluctuate, and that's kind of a trend we've seen for 3 years now, even though reporting does seem to fluctuate a bit, it doesn't impact at least the state overall rate as much, which is good that we can use that almost as an inference for what to expect. But on a localized level, though, especially in smaller counties, having these higher reporting percentages, though, really does stand out, really does make a difference at a local level. So again, a lot of the drive this year, though, was our private schools. We got significantly more private schools that reported. So I'm glad that's catching on in the private school sector. This is a thing, and this is something they should be doing. We go ahead and go to the next slide here. We're going to talk about the child cares and preschools. Yep. So same kind of idea here, though. Pretty much the same trends that we saw, but one thing I do want to highlight in this case that was a little different. All vaccines for child cares and preschools this year had a less than 2% non-compliance rate. I think that's really awesome to see. Kind of look at it the way of compliance and non-compliance is what's in control of the facility. They can't exactly control if a parent decides to take their legal rights and exempt from a vaccine, but they can control actually collecting that exemption on time from parents and admission of students. So that's really good to see that we have less than 2% non-compliance, and that seems to be a trend to get non-compliance dipping down. Exemptions for child cares are a little bit above what they are for K-12, but still hover right around that 3%. And again, almost all of them are personal belief exemptions. Website kind of breaks down those by percent of vaccine too, and you kind of see it more visually too, how overwhelming it is that they're all personal belief exemptions versus religious or medical exemptions. Childcare and preschools, though, this is where we see, I think, the greatest rise in reporting, going from 74.5% all the way up to 87, and looks like 2/3% there. 15,000 more kids that we got reported this year. I was, for the 18-19 data for last year's data, or I guess 2 years ago's data, I was a little disappointed with only getting about 75% of the child cares reporting. I think I kind of shared the disappointment with people, and it looks like everybody very well responded, though, in getting us much higher numbers and stuff that we can have certainly a lot more confidence in seeing. Especially too when we're looking at localized levels, child cares and preschools in a lot of counties. Though it was great to see that we've got more data for those localized counties. Lets us have a little bit more confidence, though, that the rate we're seeing for those counties, those jurisdictions, is more closer to truth. So again, very, very proud of everybody for this year for stepping up. We can go ahead and go to the next slide here. We're going to talk about the kindergarten sections as well. So we do break out kindergarten separately. It's for a report that we send to the CDC every year, and it is also the focus of, this whole project. I feel like that the K-12 and the child care and preschool sometimes gets lost because the CDC reports out the kindergarten numbers. They line every state up all the way from best to worst, and they give the interpretation that this is a ranking and you guys should never rank those that way whatsoever. It really is not a good idea to do, even though they will do it. Everybody will do it. The media will do it. We'll do it. It's not necessarily data appropriate to rank everybody that way. Every state does follow different rules as far as reporting, when reporting is done, what the criteria are for categories. There's a good document actually that comes out from the CDC every year about not doing that exact same thing. But however, Colorado, if you do rank them that way, tended to always rank last or very near last in kindergarten vaccination rates, particularly around MMR. So that was our big focus this year, was kindergarten MMR. Generally, though, we can see that all of our immunization rates across vaccines very much up this year for kindergarten. Significant rises, and we saw very significant declines in non-compliance. Well, exemptions pretty much were very constant. And I think that's a really, really interesting and good takeaway for this. We're going to kind of get into all of those topics here in just a moment. I just want to take a moment real quick here. You guys see two graphics moving from 1819 to 1920. And I mean, even if you just look at the red bar and how much closer the green and the blue got to the red bar, I mean, it's even visually a noticeable difference, not even just looking at the numbers. But yeah, significant rises across all vaccines for kindergarten students. Very, very promising to see. So go ahead and go to the next slide. We're going to kind of dive into all of this in a little bit more detail. So vaccine goal, I kind of alluded to this a little bit. As I said, we were focusing on kindergarten MMR, and maybe some of you are aware of, again, there's a lot of you on this call. We did have a statewide goal to get kindergarten MMR fully immunized rates to 90% or above. And I'm really happy to say we got 91.1% this year, kindergarten immunization rates. I believe that is the absolute highest that we've ever had for kindergarten class. And really, though, I don't want to overshadow any of this, though. This was a huge undertaking to happen. I did go back and look at every year that the CDC has collected kindergarten MMR rates from every state. As far as a percent increase is concerned, this has only happened 12 times. They've been collecting data for over a decade. So I think that's 12 times across any state. That's huge, and that's only going from last year's to 90%. Us exceeding that. I didn't exactly do those calculations, but it's less than 12 times, I'll tell you that much. So a really, really great job from everybody. It is. I'm kind of watching the chats pretty halfway here, but what Aubrey Hill says, though, it's fantastic news. It is absolutely fantastic news for us to hear. We want to keep doing it, though. we want to keep it going, of course. But no, we go ahead and go to the next slide, though. Kind of want to look at a little bit of how we did this, though, and then we'll kind of get into some takeaways. So again, I kind of mentioned a lot of our unsung vaccination here. It's school nurses, our nurse consultants, LPHAs, healthcare providers, everybody who kind of work to actually do this work on the ground. I mean, we collect the data, we look at it, we get excited about what the numbers are to report, but it's all these people that actually did the work. They're the ones that did the jobs. And so my hat's off to you guys, though, for making this all happen, for making this work, and I hope in some small way I was able to support you guys in that role too, but fantastic job. One thing though that we did notice is we put a real big focus on catching up students who are not up to date for kindergarten MMR. We kind of gave that as a task for all of our school nurses. Focus on these kids first, and I think it's really apparent that they did that. They focused on those first. They gave those parents the most time to catch their kids up on vaccinations. And now again, hats off to you guys. But I do want to talk about where this increase came from because I think it's interesting. I think that there's a lot of maybe common belief, though, that in Colorado with the anti-vaccine sentiment that's here, a rise of this kind of magnitude wouldn't be possible. It would be really hard. It would be challenging to overcome those barriers of that vocal group. Exemption rates for kindergarten MMR decreased by 0.04%. I almost feel irresponsible even saying it decreased by 0.04% and going out that far. I mean, now we're talking about a handful of children at that point. It is constant as far as I'm concerned. So if exemption rates are constant, but we saw those same exact giant rises in fully immunized, they all came from our non-compliance section. We had far less non-compliant students for kindergarten in general, not just for MMR. And again, if you guys get a chance to check out the dashboard, or if I get a chance to show it to you, I'll certainly highlight that section where you can really see just a dramatic drop in the non-compliant section. And I think, though, that speaks to not only having, possibly an anti-vaccine group that's there, but having a separate problem too, and that's the non-compliance aspect. And that's something we can directly address. And I think we showed that in the 1920 kindergarten immunization rates, that if we attack the non-compliance section, we can see really great gains in vaccine rates across the board. And we don't have to raise voices from anybody that might have a counter opinion to that. And I think that was really a good win for everybody on all sides. So might be a useful thing to kind of be targeting and looking at in the future, though, as far as how many more can we extract from non-compliance? Because for a lot of those incomplete records, or no records for that fashion, it simply can also represent a slice of data that we just don't have. It's, in theory, of course, possible to assume that every student who has no record has just not turned in a fully immunized vaccination record. And that by actually collecting those and by forcing the essentially just compliance of turning in forms, we can see vaccination rates essentially rise, but really we're just getting closer to the truth. And then again, in that same theoretical approach, to be fair to everybody, it's also possible that all of those no record students are fully unimmunized as well. And then, of course, the truth is going to fall somewhere in between. So I think this is a really good testament, though, to how we can make those strides without maybe raising voices in a community, though, that would oppose this. And this almost, I feel like, works really well in tandem when we try to take a slice of that non-compliance and see actually what is in there, what's going on with those students, because it represents a hole in our data. And I think we've started to show too that when we attack that hole in the data, we start to see that we get more quality data, as well as data that shows Colorado is doing better than maybe we previously thought. So let's go ahead forward on the slide one bit here. Thank you. So I kind of alluded to some of this before here, though, but we did see a really big positive externality from this. And that's the small bit of the economist that is still holding me using the word externality. I was proud to actually be able to use that. So we saw kindergarten MMR rates jump up, and that was our big focus. So we were really hoping to see those rates jump up, and we did. But we also saw every other immunization jump up along with that, almost kind of follow that trend. And I do think, though, that that's us focusing, though, on one vaccine, giving people one clear directive, though. If you're not up to date for MMR, send home parent letters, get these children up to date. And then we kind of let those other vaccine heroes that I was talking about before, our primary care physicians, local public health in the case of immunizing students too, take hold of it and go, look, child's also not up to date for X, Y, and Z, the rest of the vaccines, and also then catching them up then from that point. So I think this is a really good approach, because MMR is one of the simplest vaccines for, at least for evaluating a shot record, to know if a child is up to date for or not. And then, kind of almost shifting some of the harder ones, though, onto primary care docs, essentially, local public health, other immunizing partners, though, to help catch them up in the rest of their vaccines and getting them in front of of those individuals too, I think is big. And I think we saw that by just focusing on one vaccine, we can see gains in the rest of the vaccines as well. And so that might be something, though, as a good takeaway for people who are trying to have some targeted interventions or some targeted focuses on things. If we focus on one vaccine, though, we don't just necessarily have to see a gain in just that one vaccine. We can see gains across the board, though. Groups before me, again, really hammered home and alluded to, the overall health of the child. And I think that's some of what goes on here, though. We focused on one aspect, though, but we saw larger gains in an overall health aspect. Just something to kind of take away, though, that, when we are focusing our limited resources on something, we can focus them, on some of the simpler topics, like the simplest vaccine to validate, MMR. And we can see gains being made in some more complex vaccines and some more complex schedules, too. So go ahead and go to the next slide if you want. Thank you. So looking ahead for next year, though, some goals that we have. The goal is now to hit 92% for kindergarten MMR. I think that's going to be even more challenging. I thought going from 87.4 to 90 was going to be an impossible feat. We hit 91%. Now we're trying to go from last year's 91 to above 92 during a global pandemic, of course. So we're just going to raise the bar even more on everybody who we've constantly been raising the bar on. But I do want to echo, though, if we're able to make the gains that we saw last year, which I don't really think that anybody had a true belief that we would do that or we would see those kind of gains being made here. I think we can do this too. I really do. I think this is certainly something we've proven that's possible. The environment's going to be challenging this year. It's going to be unique for everybody. And I think we're going to kind of have to be pretty fluid with how we go about this. I do, at the bottom of this slide, though, I do kind of highlight that electronic district reporting. I think that's a big thing to leverage, too, since that does take some pressure off of a group of people or school nurses who are going to be more burdened this year anyway, just by the nature of what's going on. I mean, the presentations before me did a great job of highlighting all of the health challenges within the schools that are going to be taking place. So this electronic reporting does help to take some pressure off of them, too, and I think this is the right time to start taking pressure off of an already overburdened group of people. But I'm happy to do anything that I can as far as collection of vaccine, interpretation of data, entering data, and anything at all in between that I can do. I can't look at kids' shot records, legally speaking. But anything that's not that, I can certainly help do, and I would love to help do. Not only just to meet this goal, but to kind of make you guys' job easier. Those reporting increases that we saw, I want to see the same things this year too. I don't want to see a lag in the percent that reported. We kind of saw that after 17, 18, we saw a big rise in the number that reported, and then 18, 19, we saw that kind of drop. Kind of some complacency, I think, that may have set in. I really want to kind of get out in front of that, though. I don't want to see that complacency this year. Don't want to see that it was easy last year, it'll be easy this year. We still need to get this stuff done. Please contact me. Let me know how I can make it easier for you specifically, down to a facility level if there's something I can do just for you guys. I want to do that. So let's try to make this as easy as we can to collect this data, and again, to put you guys as all focus on where it should be, helping to keep kids healthy, helping to keep kids immunized, and let's try to put some of the data work on me. More than happy to kind of take that over. One thing that's not on this slide, and that's just because of when I received the information, but I do want to make mention of it, though. We do have a lot of schools, school districts that are going back in some kind of a hybrid format, or anything in between of everybody online and everybody in a classroom. We're kind of seeing all different kinds of mixed methods of getting kids back to and learning. But it is still a requirement to collect the immunization records and immunization forms, even if those children are going to be doing some of their learning at home, in hybrid fashion or whatnot. These are still forms that need to be collected for this upcoming school year. So just to kind of, make mention of that too. I know that's going to be a bit of a challenge as well. And then as far as not wanting to see a rise in no records, again, that hole in our data. Just try to make as much of a push as you can to collecting those records. And again, if that starts to become a pain for some people or whatnot, get up with me and let's see if we can't rectify that just a little bit. If you want to go ahead, we can go to the the following slide here. I think this is coming up on the last one that I've got for you guys, so you can stop listening to me drone on and on about things. But our new 2020 data visualizations, we did kind of redo those all, in the middle of redoing a lot of the COVID work that I've been a part of and the COVID state dashboard. I don't want these to lag at all. We did implement some some new features in there. Most of the drop-down menus that aren't selecting your individual facility or aren't selecting your individual district, those have been replaced with some buttons. Makes it kind of easier to toggle between years or toggle between survey types. And then also kind of shows you what all is available pretty much front and center. One of the big eyesores, that's my second bullet up there, was if you're comparing anything, comparing two districts, comparing a school to a district, anything along those lines, the axis for the categories would adjust, so they weren't equal to each other, and it made it so you really couldn't compare the magnitude of the bars very accurately. And that didn't really present, I feel like the most ideal picture. So we've made some improvements there. All the axes in each of the categories are fixed at the same length. They'll adjust to try to give you the most optimal viewing. And again, if you check it out, I think you'll see it pretty quickly. And then our comparison section to compare schools or to compare types of schools was all redone. Try to present more information in front of you at one time. One of the things we noticed was people don't want to compare 50 schools. They usually just want to compare about 5 or 6 of them. So we kind of optimized it to where you can compare a smaller group of schools, but you can see more information from that small group of schools that you're comparing. And I think that's going to help people make make some better and more informed choices. The link for all our visualizations is there as well, and there's also all the data that's available to be downloaded. Same thing as last year. None of the data downloads changed. We still roll things up by county, still roll it up by district for you, or give you all the raw data, and then you're welcome to roll it up however you want to. But that's really all I got. I think the next slide, the last slide, here's my contact information, so you guys get the slide deck and whatnot, you know how to reach me. My desk phone is still on there, just more of a formality, but I really don't recommend calling that if you can't tell. I'm working in my house like everybody else. You'll hit a voicemail. Shoot me an email. If we got to talk, I'm more than happy to call you guys. But yeah, please hammer home the email. But yeah, that's about all I've got. Julie, again, I'll answer your question. I know everybody else has got questions on there. I didn't see them. I just saw hers pop up. The due date as of now is still going to be the same as last year. We're going to move it to the January 15th date. So that's where it is right now. But again, we are going to try to be as flexible and adapting as we can to, very uncertain times ahead. So it will not be before January 15th, I can tell you that. But as far as any kind of extending it or whatnot, we're certainly just going to kind of have to take that one step at a time as the situation on the ground changes. But that's all I've got for you guys. I just want to give you guys all, like I said, a quick run through of what everything looked like. I think we've got we're supposed to leave 10, 15 minutes for Q&A. I hope I left that kind of time for you guys. But yeah, thank you.
Great, thank you so much, Tavio. So now we're just going to open up to a Q&A. We've had some questions come through the chat box. So I'll start off with some questions that are for Heidi and Susan. One question that we got was, how long is an asymptomatic person contagious? Susan, I don't know if you are you okay with answering that?
Yeah, I am. Sorry, I can't turn my video back on. Yeah, so asymptomatic, we're just still deferring to the CDC, who currently still says 14 days. So until we know otherwise or have any form of evidence otherwise, we're just aligning with CDC on that.
Great, thank you. The next question for you, Susan. If a teacher's 3 kids are sick with COVID and high-risk symptoms, should they stay at home for the 14 days?
Yeah, that's a great question. So generally, yes, but it's really important to have an encounter with your primary care provider on this topic, because if there's an alternate explanation for the symptoms, for example, like allergies, then they might be able to return to school sooner. However, if there's not an alternative explanation for their symptoms, they'll need to stay home for 10 days. If you get a test and have a negative COVID-19 test, then that would supersede that 10-day isolation. But so if you have a negative test, you could return to school after you have been fever-free for more than 24 hours not using fever reducing medication, and improvement in all of your other symptoms. Does that make sense? Yeah. Okay, so COVID test would help out in that situation.
The next question we have is for Tavio. This question says, is there somewhere that we can obtain a step-by-step instructions on how to submit our school data electronically? And how do we get our school signed up for this?
Muted. There we go. Yeah, use my contact information at the end of that there. I'm going to throw it up here in the chat for you guys all too. Send me an email. Let's kind of talk about it again because it does involve some district IT stuff. So we want to make sure that they're all on board. We get all of our bases covered, but I want to take everybody's time with going through all that. Send me an email though, and yeah, we'll certainly we'll get the process rolling and getting you guys configured for that. As long as on your end it's something that you're feeling like when we talk it's going to be something you're comfortable doing for this year, we can do it for this year.
Thank you. Let's see. The next question I've got for either Heidi or Tavio, if you both want to take a stab at it. This question says, I have a lot of families reporting that they are having lots of trouble scheduling immunization appointments with their provider due to COVID. Any thoughts or guidance?
That's a really tough one. I think it depends on the practices and what their prioritization of patient appointments is right now. I would say generally our primary care practices across the state are open for business. So I'm not sure what the pushback is, or if the pushback is happening now, or if it happened months ago at the beginning of COVID. But the information I have is that primary care is open for those types of visits.
Let's see. So this is also regarding testing. This question talks about, do you know what districts are doing sewage or pool testing in Colorado? If not, that's okay.
I'm sorry, could you repeat that?
Yeah, absolutely. So do you know of any districts in Colorado that are doing pool testing?
Pool testing, is that like a sample, like sampling?
I think so, yes, where they do groups of testing.
Yeah, so I don't know of anyone doing that amongst their students. I have heard of districts doing that amongst their staff, but I haven't heard that for students.
Let's see. And if you have more questions, feel free to submit them in the Q&A chat box. Let's see. This next question is for Tavio. Could this increase in compliance be related to increased education to providers and less on inappropriate timing of doses?
It would be possible to see that, although the increase that we're seeing in compliance overall like that though, for kindergarten it's pretty significant, and I'd be remiss to say that is all one area. I think that certainly can be an aspect for it, is providers immunizing on a proper schedule, since an untimely dose would not count. We do look at the valid doses, but there's something else to consider too, and I'll use Boulder Valley School District as an example though, that implemented essentially no non-compliance, and they were really cracking down this year from a district level down on non-compliance. I think that also has a real big impact too. But no, certainly don't want to discount anything though that can have a an impact in seeing less non-compliance, more compliance. Certainly a possibility.
Susan, this next question is for you. How are you dealing with the reported COVID test inaccuracies?
I don't know that we have a standard response to that, because I think there's just so many other factors. So I think a COVID test is a tool that your doctor can use in helping to diagnose, but I think, I don't know that we have a test that has, 100% accuracy at this point. So I feel like that just has to be discussed with your doctor, and considering your symptoms and your onset and your exposures to other known people who might have it. It's a whole myriad of factors. That test is only one of them.
Tavio, this next one's for you. This question is, how do healthcare providers report vaccine data to CDPHE?
Healthcare providers reporting vaccine data to CDPHE. Our healthcare providers that would be coming in through SIS, Colorado Immunization Information System. So that's how healthcare providers are going to essentially report vaccine data to SIS. But all the stuff that I presented on, though, although the data can be in SIS, the reporting that our child cares and preschools, our K-12 schools do is not done through SIS. It is done through a custom application that we've built. Although there's nothing that stops a child care preschool from using SIS in order to compile their vaccine records and using that almost as a student information software for vaccines. But we don't query or look at SIS data when determining our school or child care rates at all. If SIS is used, it's at the facility level, which is certainly an appropriate use of SIS for that facility to be using. We encourage them to use that as well. But healthcare providers would submit it to SIS, and then a child care preschool or school may use SIS in order to compile this report. But the report is independent of SIS.
Great, thank you. Susan, I think this is one of the last ones. This question is, are there any guidelines for school nurses to be able to administer COVID tests in conjunction with LPHAs or local departments of public health?
So I don't know of any current programs or guidelines in place for school nurses to administer tests. And there's a variety of different types of tests. And if it's going to be governed by your local public health agency, then they would be the ones to create those guidelines. Currently, our nurses through Children's Hospital of Colorado, we have a team of 35 school nurses that we contract out to different districts. We do not currently provide that service.
Thank you. So I think those are all the questions that I'm seeing on this and that weren't answered in the chat box. So next, we're just going to go over some Immunize Colorado updates. And so I'm going to scroll back a little bit, but if there's any other questions, please feel free to contact Susan, Heidi, or Tavio, and they'd be gladly to answer your questions. Again, this recording and their slides, we will be able to put up on our website, so you have access to that as well. I'm just going to scroll back a little bit to give you a little, just backtrack a little. So just from us on the, just a couple of Immunize Colorado announcements. We've got some new resources to encourage parents to stay current with vaccinations during COVID-19. This resource is found on our Immunize Colorado webpage, and it's translated into 12 different languages. Please check it out. It's a very great resource. Other updates to our annual SOUP event is scheduled for October 22nd. And this is an evening of celebrating and raising critical funds and awareness for immunizations. This year's event will be virtual to ensure that all of our guests are safe. You can register for this event at immunizecolorado.org. And there's more, tickets will be on sale in the coming weeks. If you have any questions about this event, please email Emily Clancy at childrenscolorado.org. I also just want to give a welcome to all of our Colorado Immunity Corps members. Immunize Colorado has rolled out an AmeriCorps Vista program where we've hired so far 7 volunteers to be members across the state to increase knowledge and increase access to vaccinations in rural and more high vulnerable populations in Colorado. So welcome our members. Next, I'd like to just give you all an update from our executive director. Stephanie, are you still online with us, and can you still hear us?
Yes, I can. Can you hear me?
Yes. If you want to just give it all of the.
Can you guys hear me?
We can.
Okay, great. Great. Just two quick updates. As many of you know, there is a new immunization law that was signed by Governor Polis in June, Senate Bill 163. Now the State Board of Health is working on rulemaking to implement the new law, and I think this year is considered sort of a planning year to get all the pieces in place to implement the new law with full fidelity. So there was just an early stakeholder comment period where lots of people had an opportunity to just look at the new rules and provide comments. The full rulemaking process will occur in the fall with additional opportunities to provide comment. So stay tuned for that. And then I just wanted to let everyone on the call know that Immunize Colorado is launching a new task force specifically focused on vaccine equity issues to address both the disturbing trends that we've seen in terms of COVID and how it has disparately affected communities of color, as well as to help provide information and resources around ensuring that communities of color are a priority for the new COVID vaccine. So stay tuned for that in terms of a formal announcement and some exciting new work that will come out of that task force. Any questions about either of those, please feel free to email me or anyone else at Immunize Colorado. Thank you.
And next, I just wanted to highlight one of our VISTA members that's currently serving at Immunize Colorado with us. She's taken the time to restructure and try and lay out these social distancing measures at vaccination clinics. So in our last few minutes, I just wanted to give her the opportunity to share some of her research and some of her slides on best practices. Ellie, are you able to talk, and can you hear us?
Yes, I can hear you. Can you hear me?
Yes, go ahead. And please let me know when you'd like me to switch the slides.
Okay, great. So like they said, my name is Ellie DeLay, and I'm currently serving as an AmeriCorps Vista with Immunize Colorado. Over the past month, I've developed this on-demand training for healthcare providers and public health departments on best practices and recommendations for conducting socially distanced vaccination clinics. I think this training will be especially important as kids start going back to school and as we prepare for the flu season this fall. Especially if we're trying to make sure that we reach that 92% kindergarten MMR rate that Tavi mentioned earlier. You can find this on-demand training on our website by following the link at the bottom of the screen. Additionally, you can contact me at elizabeth.delay@coloradoimmunitycorps.org if you have any questions about the training or would like any additional resources or sources for the information in the training. So with the last few minutes of our webinar today, I'd like to walk you through some of the major sticking points of the training. I promise to make it quick so that you guys can all get along with your day. Next slide, please. Great. So the first part of my training goes over the importance of maintaining childhood vaccinations during COVID-19. Unfortunately, since the beginning of the pandemic, we've seen that immunization rates have decreased by over 21% around the United States as public health departments and pediatricians' offices have been closed. Additionally, if we take a deeper look and look at specific childhood vaccination rates, we've seen that MMR vaccination rates have decreased by over 50% nationwide. While these rates have started to uptick as provider offices and public health departments have reopened, there is still a significant number of children that are behind on their immunizations. Additionally, many health experts are concerned that flu will be and COVID-19 outbreaks will happen at the same time, and this could put a substantial burden on our healthcare system. So really in the next couple months, we need to put a lot of effort in ensuring that our children get caught back up on their routine childhood vaccinations and that our communities are vaccinated for flu. Next slide, please. So in order to help us get caught back up on these vaccinations, I have laid out, my training goes through the basic structure of a socially distanced vaccination clinic and a few best practices as recommended by the CDC and other leading health organizations. Some of these best practices include establishing a unidirectional flow through the clinic, utilizing an online registration and appointment schedule, and screening patients for COVID-19 when they arrive at your clinic, and ensuring that patients and staff have adequate PPE. All of these measures can go a long way into ensuring that your staff and patients remain safe and healthy throughout their time in your clinic. Additionally, my training goes through estimates of costs and amount of PPE that you'll need for your clinic so that you can plan adequately for when your clinic comes. Next slide, please. And then finally, my training goes through some advantages and disadvantages of 3 socially distanced clinic models, including a traditional clinic, a drive-through clinic, and a mobile clinic model. It goes through the different resources and staffing needs for each of these and different environments such as schools or community centers that you might want to use each of these models in. So I hope that you guys are able to access this training. It's about 30 minutes long and runs through a lot of these topics in greater detail on our website. So that's all I have for you guys today. Please feel free again to reach out for me or anyone on my team at Immunize Colorado if you'd like any additional information about this training or any additional resources about holding socially distanced vaccination clinics.
Great. Thank you so much, Ellie, for giving a brief overview on that. And with that, I think that is everything. I don't see any other questions in the chat box, but please, if you do have any questions, feel free to email us and we can relay those to our guest speakers. So I just wanted to say thank you so much for participating in today's webinar. Thank you, Susan. Thank you, Heidi. Thank you, Tavio. Your information that you presented today is very helpful, very informative. And we're just very grateful that you were able to present today. And with that being said, we will have a September webinar that's focused on maternal immunizations on September 22nd, and more information will come on that as well. But with that, I think we are all wrapped up, unless Heidi and Tavio, do you have anything else to add? Or I'm sorry, I'm Susan, Heidi, and Tavio.
No, I'm good. Thank you for the
Not
opportunity.
for me.
Feel free to email me with any questions, or if you'd like any of those symptom pads or anything, happy to share.
Thank you. Well, thank you so much and have a good rest of your day, everyone.